Okay, so the next presentation is a keynote presentation from our international guest, who's Professor Sara Cosgrove. She's a professor of medicine and epidemiology at Johns Hopkins University. She's an infectious diseases physician and has led their antimicrobial stewardship program for a while. She wouldn't put any years on it, so I'm not going to either. But certainly she's extremely well published in this area, and as a clinician she has fantastic insights in terms of this whole problem associated with antimicrobial resistance and how antimicrobial stewardship itself can really provide some important solutions for better care for patients. So her presentation will be antibiotic stewardship in the inpatient setting, notes from the field.
Thank you, Jason. And thank you for inviting me today. I always find that it offers a huge recharge to see what's going on across the world in this, big, giant project that we have to improve how antibiotics are prescribed and reduce resistance. And it's fascinating to see how people are, what's going on, how people, work within the systems that they have to promote stewardship. And so thank you. It's really a huge pleasure. So this talk is going to be in 3 parts, and the first part, because this is the AMR Forum, I did want to address the issue of really, does stewardship really reduce antibiotic resistance? I will provide some data, hopefully that will convince you that that is true. Maybe you already are convinced, but if you're having any doubt, we'll talk about that. We'll also throw C. diff in there. And then the second part of the talk is to talk about types of stewardship interventions that I think lead to antibiotic use. And I will say that I'm going to talk about work that I've done, and it's not for the purpose of self-promotion. It's really because I can talk about the studies, because I kind of know all the details of the studies, and just tell you some things that we learned in the course of doing the studies. So the studies that I'll mention are one where we compared pre-prescription authorization to post-prescription review and feedback, which I think are the kind of core stewardship interventions, trying to explore self-stewardship using an antibiotic timeout, syndromic stewardship, which I talked a little bit about yesterday, and then finally engagement of nurses. And this is a surrogate for really engagement of all healthcare workers in stewardship, moving away from the model of just physicians and pharmacists doing stewardship. And then finally, at the end, I'll tell you about the Agency for Healthcare Research and Quality Safety program for improving antibiotic use, and how we developed this using some of our experiences. And when I say we, there's an awful lot of people, but I specifically want to acknowledge my colleague Pranita Tama, who is my partner in crime with most of this work, as well as with the safety program. So when we think about stewardship goals, and I put in the center of this, reduce antibiotic resistance across the population, because that is really the end game. That is what we want to happen with stewardship. But I also think it's perhaps one of the most challenging outcomes of stewardship. And I think it's important that we look at and remind ourselves of what else are we trying to accomplish with stewardship. And so all of my satellite ovals are other things that I think we're trying to accomplish in stewardship, including reduction of C. diff, reduction in adverse events, reduction of emergence of resistance in individual patients, and then reducing and optimizing antibiotic use, which for the most part, I think are similar. And I think these are the outcomes that are not only perhaps sometimes easier to measure, but also ones that we really should view as things that help us in society in terms of reducing healthcare costs and reducing hospitalizations and all of those things also. So this is a quotation that could make you feel like we're not going to win. It's from Bill Bryson, and he said, because we humans are big and clever enough to produce and utilize antibiotics and disinfectants, it's easy to convince ourselves that we have banished bacteria to the fringes of existence. Don't you believe it? Bacteria may not build cities or have interesting social lives, but they will be here when the sun explodes. This is their planet, and we are only on it because they allow us to be. So we're in trouble. However, I have decided that on this topic of resistance and stewardship, that I'm going to choose to see this as a glass half full issue. And that we have to believe in our hearts that we are reducing resistance when we do good stewardship, because otherwise we need, we'll have to revisit our entire profession, basically. So we don't want to do that. And there are data that seeing the glass half full is actually associated with, a happier existence and less depression and all of that. So I think we all need to choose, despite Bill Bryson and the bacteria, to view this as a glass half full issue. So to help you with this, I want to talk about some of my favorite studies that have looked at this issue of does stewardship reduce resistance. And I like to point to these studies that were done in Scotland because they make me feel good about what I do every day. I will recognize that obviously Scotland is a very small country, and these data are actually not even from all of Scotland, they're from a portion of Scotland. But I choose to ignore that because I see the glass half full. So these were a set of studies published in 2015, 2017, and then just recently the long-awaited gram-negative data earlier this year. And basically, these were nonlinear time series analyses and quasi-experimental studies to assess the impact of the Scottish antibiotic stewardship and infection control plan on hospital and community MRSA rates, hospital and community C. diff rates, and rates of resistance in E. coli, Klebsiella, and Proteus in blood cultures at hospital admission. That's a bit of a mouthful. And this was quite a few hospital admissions and quite a few primary care patients in Northeast Scotland that were affected by this national stewardship program. And it is a stewardship and an infection control program. The stewardship interventions were a regional stewardship program with pharmacists and infectious disease specialists, and it was funded by NHS Scotland starting in 2008. And I think that's a very important point, that money went into this to support people to do this work. And of course, we have to recognize that the NHS, whether in Scotland or England, is a little unusual. It is certainly not a model that we have in the United States in any way, shape, or form. It is a top-heavy approach where things can be implemented kind of because you're going to do it, which is the opposite of what we have in the United States. I don't know where Australia fits into that, so maybe a little in between. And so the main intervention in this program was to recommend against the use of the 4C antibiotics, which as an American, none of these really sound like a C except clindamycin, but I recognize there are alternative pronunciations. So they worked hard to not use fluoroquinolones, cephalosporins, amoxicillin, clavulanic acid, and clindamycin, required approval to use these agents from a microbiologist or an ID physician, including in the outpatient setting, and hid the susceptibilities. So they were serious. And then they did root cause analyses for all C. diff episodes, which is kind of a stewardship intervention and kind of an infection control intervention. And there were pretty aggressive infection control interventions going on at the same time: a national hand hygiene campaign, monthly auditing of hospital cleaning, MRSA admission screening, and basically C. diff screening. So all patients that had liquid or semi-solid stools had C. diff testing done. So just quick to the results. This is MRSA reduction. On the panel on your left is the hospital data. There were 3 hospitals. This is one of the hospitals, but they all looked about the same. And the little green dots are MRSA. The blue shaded area to the right of the dotted line is stewardship time. And you can see at the bottom of the hospital graph that the hand hygiene and other infection control work had been going on before the stewardship intervention. However, there is a fairly precipitous decline in MRSA after stewardship was added into the infection control work, with maybe a touch of replacement by MSSA, but probably not statistically significant. And overall, there was a 51% reduction in hospital cases of MRSA after the stewardship started. And then there's a similar graph on your right for community-acquired MRSA, and there was a 47% reduction in community cases of MRSA. Similar, but maybe not quite as dramatic for C. diff. In the hospital, stewardship starts at the dotted line. It looks like C. diff was going up, and then after stewardship is added into the infection prevention work, the rates go down for a 68% reduction in C. diff, and the same thing in the community, where maybe things were already starting to go down a little bit, but overall a 45% reduction in C. diff. And perhaps my favorite picture from these papers is this C. diff ribotype distribution graph. So all of that yellow are the epidemic strains of C. diff. And recall that one of the features of the epidemic strains is that they are fluoroquinolone resistant. And so I think that this is kind of a clear demonstration that if you stop using fluoroquinolones, you can control the epidemic strains of C. diff. If you're a glass half empty person, which we're not, right? You might say, well, this is just the tail end of the epidemic. This is, you know, what we would have naturally expected in an epidemic. But I would just say, look at all those graphs. And when stewardship starts, the rates go down. And so that's why I'm not a half empty person. And then finally, gram-negative resistance reduction. And this is a big deal, right? And you know, in our world of trying to reduce C. diff, reduce resistance, we're worried about the gram-negatives. And I'm not sure that we know how effective stewardship is in reducing the gram-negatives. And this is, of this work, the least impressive, not because of the authors, but because of just what they found in terms of the impact of stewardship. So this is, that they looked at E. coli, mainly E. coli, 82% of the isolates were E. coli, Klebsiella and Proteus bacteremia on hospital admission, and looked at resistance to quinolones, cephalosporins, and amoxiclav. And if you look in that middle row of antibiotic prescribing, you can see that there were these really precipitous reductions in antibiotic prescribing. And this is the same time period that we just looked at for MRSA and C. diff. So fluoroquinolones went down, cephalosporins went down, and coamoxiclav went down with stewardship. But then if you look over to the right with antibiotic resistance, those are not impressive graphs. For fluoroquinolone resistance amongst the gram-negatives, they did see a statistically significant reduction in resistance, but it took a year and a half, and it's somewhat wimpy. If you look in the middle panel, that's cephalosporin resistance. It took 3.5 years to see a statistically significant change in cephalosporins, and it was really a stabilization, not a reduction. And then finally, with amoxiclav, there was no significant reduction in resistance. So I don't know what to make of this. I think it probably means that there are other factors with gram-negatives, although, again, it's not terrible. There was still a reduction seen. So I think what comes up a lot in our practice is, why don't I see these kind of reductions, even though I work really hard in stewardship in my hospital? And I think some of this is because, as we know, rates of resistance are driven by factors other than antibiotic use. Infection control practice is a big one, and there was a lot of infection control going on in Scotland. And then where your patients are coming from is a big predictor of whether you're going to have MRSA or resistant gram-negatives or even C. diff. We also know that the effect of decreasing antimicrobial use on resistance may take a long time. This is what we saw in Scotland, and so it can be difficult to find the correlation between use and resistance. And then the other thing, and this is something I hope we get some follow-up data out of Scotland for, actually, is that they definitely saw reductions in resistance to the antibiotics they targeted, but they actually had increases in antibiotic use for the other antibiotics that they replaced those antibiotics with. So it will be interesting to see if there's an increase in resistance to those antibiotics. And I think we probably see a lot of this in the hospital. We'll stop using something because we're worried about a bug, and then whatever we start using instead, we start to have resistance to that. I'd also say we don't have a standard definition for successful reduction in antibiotic resistance. Everyone defines this differently. And then finally, I want to just make the point that an antibiogram in a hospital is suboptimal to track resistance. It's what we have, but it's suboptimal. So what is the trouble with antibiograms? And I kind of feel sometimes like the antibiograms that we constantly generate are a little like the tribbles, just constantly being generated, and we're like, what should we do with this? So what are some of the troubles? It's generally that you're only looking at the first isolate from a patient. There are many resistant isolates that are acquired before hospitalization. And you can't do anything about that when they're in the hospital. You can prevent the spread, but you can't necessarily change the fact that the person has that. And they don't detect emergence of resistance in the hospital. If you're capturing the susceptible version of the bug and then bad antibiotic use leads to resistance, you don't capture that in the antibiogram. There are strategies to make different antibiograms, but our standard antibiogram has these issues. You're only looking at clinical cultures. Antibiograms don't have colonizing organisms in them. And you know, colonization is probably the first step of resistance happening and then causing an infection with that resistant organism. And then also, you know, antibiograms are showing a proportion of resistance, and an increase in the proportion of resistance doesn't necessarily mean that the burden has increased. You could have overall reduction in both the susceptible and resistant form of the bug, but still have a higher proportion of resistant bugs. Breakpoint changes can make comparison over time difficult. And really, I think the best way, if I had the most perfect data and the most perfect data analyst to look at resistance would be to look at emergence of infection or colonization with resistant organisms at the individual patient level as a rate. And this is tough. In the US, we do a lot of MRSA surveillance. We usually know when a patient has had emergence of MRSA, but we don't do surveillance for gram negatives. So we only find out that a patient has emergence of resistance when there's a clinical culture that shows that. And we probably are missing a lot of emergence of resistance in the gut by not doing stool surveillance. Not advocating for that, but just in terms of measuring what we're doing, we don't capture that emergence of resistance. So some observations for this argument that don't worry, we're doing okay. If we do good antibiotic stewardship, we will reduce resistance. I think there are enough data out there, and there's some meta-analyses and other things that also support this position. However, I think we all have to remember that we have to couple our stewardship work with infection prevention interventions. We really should be working very much, not even just in parallel, but kind of interdigitated. We need to remember to span all areas of patient care. I'm mainly talking about inpatient today, but in Scotland, it was an inpatient and outpatient intervention. And we have to prepare for the long haul. Remember, it took 3.5 years to see a stabilization of cephalosporin resistance in Scotland. So we can't snap our fingers and see our results, even though we'd like to. I think there's strong data that stewardship is an effective approach for controlling C. diff. And I think it's hard to show that your own program is reducing resistance. So I think that's why we do need to think about other outcomes. So let's go back to those other outcomes, because in general, these are the outcomes that we have tried to look at in some of the clinical studies that we've done. So moving on to stewardship intervention strategies, what should we be doing and how should we be doing it? I'm going to go through 4 studies. The first one was one that I had wanted to do for a long time, and it was to compare pre-prescription approval versus post-prescription review and feedback. At Hopkins, we had actually had pre-prescription approval since 1985, so we were early adopters in this. It happened when John Bartlett, who came to be chief of infectious diseases, said, why isn't ID in charge of the antibiotics here? And so that's how the pre-prescription approval process began. And so that's what I inherited, this approach. And I had always been interested in understanding which was better, or what were the advantages and disadvantages of both. And we have an unusual setup on our internal medicine wards in that the house officers get assigned to a firm when they arrive in July. And they are on that firm for the whole 3 years of training. And in a given year, that firm has one attending, and it's the same attending for the entire year. So you have the same house staff, the same attending for the whole year. So we felt like we could really study by adding and subtracting these stewardship approaches on the medicine service. So we started having 2 firms stick with the pre-prescription approval and 2 firms have it taken away. But in exchange for having it taken away, they got visitations from us, the stewardship team, in their offices Monday through Friday to discuss cases and with written recommendations. And we felt that it was important both to speak to them in person as well as to give them recommendations so they didn't forget what we had spoken to them, and so have that written down on paper. So then we had a 1-month washout period that we tried to put in January when we have a lot of influenza, and then we swapped them in the last 4 months of the year. So these were the results of that study. So PPA versus PPRF. We looked at appropriate therapy on day 1, and there was a modest increase in the appropriateness of therapy when they had to call and get approval for antibiotics. It's not enormous. It's 66% versus 59%. Sometimes I think that's because with empiric therapy, there's not an enormous variation in what actually gets recommended. But I will say that we didn't capture the events because we couldn't capture the events where they were talked out of antibiotics with prior approval. So we're only capturing where they started antibiotics. Patients were still on therapy at day 3 in 54% of the prior approval cases and 63% of the post-prescription review and feedback cases. And really our primary outcome was antibiotic length of therapy, and we were able to decrease length of therapy by 2 days in the post-prescription review and feedback group. We didn't see any particular differences in C. difficile infection. And those numbers of the length of therapy included both inpatient antibiotics and outpatient antibiotics. So here's just a snapshot of the year. So the green people were the ones that had the post-prescription, the prior approval taken away. So everyone starts around the same point, and the green people have our visitations Monday through Friday, and the purple people, the purple firms, just have to call for approval. They're the control group. So then we switch, and so the green people are the same people, but the green people go to prior approval. So they have this nice decline, and then it stays around about stable for the time period where we're not visiting with them every day. The purple people are the prior approval people, and so they kind of looked exactly the same with no other intervention. And then when we started doing post-prescription and review and feedback, we did see a decrease in their antibiotic use. And then everyone kind of ended up in the same place at the end. So it looks like the prior approval intervention in the green people did have some sustainability. It's possible that they just got better with their antibiotic prescribing over the year. But I do think the fact we were there all the time probably contributed to the sustainability. So what did we observe from this study? And I just said this, but in-person office visits and written recommendations likely increased their uptake. And I think it tells us that stewardship programs need to get out of the office probably more often than they do. Post-prescription review and feedback is more likely to impact duration than prior approval. This just makes sense. You're capturing them, 3 days into the course. You know what you're trying to treat. And it's probably the most important thing about post-prescription review and feedback is that we can more effectively impact duration. And duration reduction is a critical part of reduction in C. diff and emergence of resistance. The fewer days of antibiotics you are getting, the less likely you're going to get C. diff or emergence of resistance. I do think that prior approval helps with unnecessary starts, which we couldn't even measure, and optimizing starts, which is important in sick people. You want to make sure you're covering the right organisms. And frankly, we found it fascinating that even though they love to complain about prior approval, like that's a source of much complaint, when we went and said, we're taking it away from you, we thought they'd be like, yes. And some of them were, but many of them were like, well, who are we going to call, when we need help? And so it was so funny when we took it away and then they missed it. I will point out that there is a recent study also done in the US in 4 community hospitals looking at prior approval versus post-prescription review and feedback. And then these 4 US community hospitals, they weren't able to implement prior approval. They just didn't have the resources to be there in real time to handle phone calls for approval. And because it couldn't even be implemented when they tried this strategy, there was no change in antibiotic use. In contrast, when they implemented post-prescription review and feedback, they did see a reduction in antibiotic use. And so I think that, because we're big and we have lots of infectious disease fellows and lots of pharmacists and lots of everything at Hopkins, we can still do prior approval, but I don't really think it's realistic for a lot of community hospitals that just don't have the same resources. So moving on to another study that was looking at a prescriber-driven timeout. So the concept of the timeout is that the team, that is the primary team of the patients, remembers, like how they remember is always an issue, but remembers at some point to kind of do a timeout and say, do we still need these antibiotics, or are these antibiotics appropriate? And this is one of those studies, when you look back, you say, why on earth did we do it this way? But what we did, which we probably shouldn't have done, is just studied a single antibiotic timeout by frontline clinicians after 3 to 5 days of therapy. And that 5 is in there because of the weekend. So we didn't want to just ignore patients that didn't get captured over the weekend. And we looked at amount and quality of antibiotic use. This was in 6 hospitals in the Baltimore, DC area, and 11 units in those hospitals. 3 sites were academic and 3 were community, and none of the community hospitals had existing stewardship programs. We adjudicated over almost 3,500 charts, and I say that because we actually did chart review on 3,500 charts, which was incredibly painful. We had a 6-month baseline period and a 9-month intervention period, but because we did the painful chart review, we were actually able to do the adjudication about appropriateness. And we, because I think it's very hard to remember even to do a timeout, did have pharmacists prompt the timeout and prompt filling out the timeout form. So we did not see any change in antibiotic days in the patients that were receiving antibiotics in the baseline compared to the timeout intervention period. And again, we did look at both inpatient and outpatient days. So there wasn't any difference in either of them or in them combined. And no change after controlling for season or unit. We saw kind of lame improvement in prescribing from baseline to intervention periods, but obviously a lot of room for improvement. So antibiotics were changed or stopped on day 3 to 5 at baseline in 50% of patients, and in the intervention period in 56% of patients. And because there were so many charts that we looked at, this was statistically significant. And then appropriateness on day 3 to 5 increased with the timeout from 55% to 69%, which is a little better, but there's still a lot of inappropriate therapy. And the main reason for that won't be a surprise to you. It was because they didn't have infection, usually asymptomatic bacteriuria, and they were still getting treated. We didn't see any change in C. diff rates or emergence of resistant organisms, but we didn't see any change in antibiotic use or duration, so that's not surprising. Observations from this study were that the single timeout had a modest impact, so people were probably paying a little more attention to their antibiotic prescribing, but didn't really change overall use. Still, I'm not completely negative about timeout because we've got to get the frontline providers to care about antibiotic prescribing, and this is at least a step in that direction. I actually think that we have an issue with frontline providers not knowing what they don't know. And it's always easier, no one likes to judge themselves. It's always easier to say, I think I'm doing a good job. I'll continue these antibiotics. And this is why I think we must have a stewardship program to back up decisions. And ideally, we would have this nice tiered approach where everyone learns to assess their own antibiotics, but stewardship is there in the background saying, you're doing a great job, or you probably can stop that. And you know, so I don't think we're going to make ourselves obsolete by moving the role of stewardship a little bit to the front line. The other thing is that we should have done this daily. Like, why we didn't do it daily, I can't remember. I think that there hadn't been that much experience with antibiotic timeouts, but I definitely believe that this is something you want to build into practice on a daily basis. It's easier to remember that way. And then build in a duration, a discussion of duration, which we didn't do. Again, I don't know why, but it's a perfect opportunity for people to think about duration. So intervention 3 of 4, this one is about syndrome-focused stewardship. And this was an intervention that we did to improve treatment of community-acquired pneumonia. And we were actually shocked to find that despite having a stewardship program and despite having guidelines for diagnosis and treatment of community-acquired pneumonia, that our median duration of therapy was 10 days for patients with community-acquired pneumonia, and that they never narrowed therapy. In fact, sometimes they would discharge the patient on a quinolone, which is embarrassing. So we said, gosh, this is bad. Like, how did we have this happening under our noses, and what should we do about it? So we thought, well, let's go talk to the people that are writing all these prescriptions. This is the medicine house staff, because there's very little CAP anywhere else other than in medicine. And so we did a survey. We asked them a ton of questions in a different way about how long they treat, how do they conceptualize de-escalation in CAP, what do they do when there's not culture data, because it's not common that there's culture data in CAP. And our goal was to really have them think a little bit more about what they were doing and how they make decisions. And the craziest thing that came from the survey was that less than 10% of them said that they gave 10 days. They all said, we give 5 days, we give 7 days. But they don't, like, we knew that they didn't. So then we were able to take this data back to them with their actual prescribing data, what they said on the survey, and get some input about what was going on and so forth. So working with them, we ended up updating our existing guidelines. And then once we did that, we tortured them for a CAP season. So every case of CAP, they got a phone call from us saying, fix this, don't do that, etc. So we were the problem in this case. I do truly believe this. So at the time, these were our guidelines for CAP, and they're terrible. Like, how would a house officer decide which antibiotic to give with that list of or, and look at the duration in red, 5 to 10 days. So if you're presented with 5 to 10 days of antibiotics, what are you going to choose if you're a house officer? You're not going to pick 5, you're going to pick 10. And so that's what they did, and it was because of our own guidelines. So we got rid of that, and we adopted, kind of based on the IDSA guidelines, 2 things. Is the patient better? And if the patient is better and it's uncomplicated CAP, 5 days. We had a lot of patients with underlying lung disease, and so we elected to let them have 7 days. I think that's probably arguable now, but this was a while back. This was in 2009, so that's how we dealt with that. And then we, for step-down therapy, gave them only 2 choices for antibiotic therapy based on some specifics, like if you actually got a culture, or if you had a urinary antigen, or if you had nothing. But they only got a couple of choices here, 1 IV, 1 oral. Intervention compared to baseline, we got the median duration of therapy down to 7 days. Excess antibiotic therapy days based on chart review went down to 1 day. Narrowing of therapy increased to 67%. 30-day readmissions were cut in half. The sample size is small, but I think if we had more people, that might have become significant. And then there was a reduction in C. difficile infections. And I think it's probably because we stopped all that fluoroquinolone use that they were up to. So then we did nothing. We went on to other things, and we didn't call them about CAP. It was hard to find CAP patients, actually. It's kind of a pain in the butt. Then we went on to our other stewardship activities, but then wondered a few years later what was going on. And our medicine training program is 3 years in the US. So we looked after all the people that had been infected by the intervention were done, who had moved on to fellowship. And we were kind of amazed to see that these results were sustained and actually even better. So we were still at 7 days. We had 0 days of excess therapy. We had narrowing in 80% of cases, and our 30-day readmissions and C. diff infections also stayed low. So what is it about this that was sustainable? And I talked about this yesterday, and I think it is much easier to engage clinicians around a message about a syndrome than an antibiotic. If I had just attacked the moxifloxacin, I don't think that this would have had the same impact. And I think that it also allows us to look at the treatment across the whole course of antibiotics. So did they get cultures if they could? Did they choose right empiric therapy? Did they narrow? And did they address duration? And I think that they felt that they had preservation of their autonomy, that they were making the decisions. I also think that they could perceive that patients weren't coming back to the hospital if they got 5 days of therapy, and that is very helpful. And we could also show them that data. The downsides of this was that it was actually difficult to find cases of community-acquired pneumonia in real time to intervene. So we had to do this complicated thing where we talked to the shift coordinator, who's the person who assigns the beds. We had to pull data on who was started on azithromycin. We had all this stuff to find cases of CAP, which is time-consuming if you want to do that real-time feedback. And then in the big picture, there's not that many cases of CAP in a hospital, relative to all the courses of antibiotic use. So it's great that they learned and all of that stuff, but we were not addressing most of the antibiotic use in the hospital. So finally, I want to talk about some work that we've done recently, my colleague Valeria Fabre, about how do we engage nurses in stewardship. So CDC in the US and the American Nursing Association have both come out with a position paper that says we should engage nurses in antibiotic stewardship. But no one is really talking about what that vision looks like and how to do it. And it's fascinating because I've talked to leadership at ANA, and they feel very strongly about this, that nurses should be involved in stewardship. But then when I talk to nurses at Hopkins, they say, what are you talking about? So I think we have a disconnect, and I think we should be involving nurses in stewardship, but I think we need to define what that means. So we had received a contract from CDC to look at this further, and we elected to look specifically at diagnostic stewardship. So nurses are obviously most aware of patients' clinical status because they spend the most time at the bedside. At my institution, the house staff now spend way more time in front of the computer than they do at the bedside. But nurses are still in the room all the time and know what's going on with the patient. And we thought diagnostic stewardship was a good target for nurses because nurses actually collect all the specimens that everyone else orders. So they're collecting the poop, they're collecting the urine, they're collecting everything. And it would probably be interesting to them to not always have to collect all that stuff. So there was a little bit of, potential motivation there. So we developed an algorithm-based, nurse-driven review of urine culture orders, and we did this on a medicine unit and a neurocritical care unit. And we targeted orders placed by physicians, but also in our education, made sure to target orders that were prompted by a nurse. So the urine smells funny. Should we collect urine and send it for culture? Or even prompted by a patient or a family member. So we thought that orders were coming from both ways, like either physicians just ordered them as part of a fever workup or whatever, but also there was some prompting probably when the urine looked funny. We made sure that we had a unit-based nurse and physician champion. We did education sessions for nurses about UTI and asymptomatic bacteria. And in those sessions, we learned that there had been no education in nursing school, no education after nursing school, about really anything in infectious diseases. So the concept of asymptomatic bacteria was not there. They didn't even know about it. And when we did the work, they were kind of really excited about the whole thing and really enjoyed learning about that. And then we did monthly feedback of data on urine cultures in a written progress report that went back to the unit. This is the algorithm. I don't expect you to read this whole algorithm, but we did specifically call out situations where urine cultures are not indicated, that we thought that there was often some sending of urine cultures for that are in that yellow box. And I will say that all of this stuff, these algorithms, are available on our website, and I'll show you that if you want to take a further look. So what were the results? So this worked incredibly well on the medicine unit, and it didn't work at all in the neurocritical care unit. And so we saw a very sustained reduction in urine cultures on the medicine unit. And I think it's because first we had a fantastic nurse champion on that unit, super engaged, super involved. And we also actually had a fantastic physician champion on the unit who was willing to back up the nurses and work with his colleagues and say, yeah, it's going to be the new normal that the nurse is going to ask you about a urine culture if it's his or her clinical judgment that that patient doesn't have any symptoms of a urinary tract infection. And we had one physician who was very unpleasant, and the physician champion told that physician, stop being unpleasant. And that was a big deal on this unit because apparently the unpleasant physician had been unpleasant with many other things and never called out for unpleasant. And so that was like a huge motivating factor for the nurses because they saw that this could happen and they could get this kind of backup. So that was awesome. So I think the team worked really well together, and that's one of the reasons for success. The other reason is that patients on the medicine unit could talk and they could say, no, it doesn't hurt to pee. And that's very helpful. Of course, it's the complete opposite in the neurocritical care unit. And again, why did we pick the neurocritical care unit? I don't know. It's always with the retrospectoscope. So our NCCU is an open unit. So even though there's an intensivist team, the neurosurgeons can come and cause problems, which is probably some of the problem. And there also are kind of wacko protocols, like there's a hypothermia protocol where they do Q48-hour pan culturing. We learned about this into the intervention. We're working on that. I'll keep you posted. And then the patients can't answer. They have catheters, they're intubated, and it was really probably the wrong population. So observations, based on our success on that one unit, we feel very positive about this idea of working on diagnostic stewardship with nurses. And I think it's an entry point. So if we're really going to move forward with nurses and stewardship, this is an entry point where we can build these relationships and build trust between nurses and physicians to think about, how we can work together. It was important, I think, that we provided adequate tools and training with the algorithms and the lectures and all of that stuff. We're going to keep rolling this out to other units. I've mentioned the need for a strong nurse champion and a physician willing to back up decision-making. And we also are working with nurses on improving respiratory cultures in the ICU and on obtaining penicillin allergy histories. We have algorithms for that, and here's our website where you can find that. The algorithms are there, we're still uploading the other material. So, taking all of that, I wanted to finish up in discussing the AHRQ safety program for improving antibiotic use and really how we applied all of our observations in stewardship to figure out how to improve stewardship capacity across the United States and engage frontline clinicians across the United States in stewardship. So this is one of those things that you furiously write and spend like a month of your life writing. And then when they call you and say, guess what? You're going to get the contract. You're like, oh no. Why did I agree to do this? So that happened to us. It was me and Pranita. And so we had to do glass half full, super duper on this. So this was a $16 million contract. We're in the middle of it. And the goal was to develop and enhance stewardship and train frontline clinicians to be self-stewards across the healthcare continuum. So we have an acute care phase, a long-term care phase, and an ambulatory care phase. Acute care ended almost a year ago, and I'll show you those results. Long-term care is about to end, and ambulatory care is about to start. And we are actually having trouble recruiting ambulatory care practices. We did not have trouble with recruitment of acute care or long-term care, and the goal recruitment was 250 to 500 sites for each. That was one of the things that was really scary, but then turned out to be okay. This was actually based on previous stewardship work that I just talked about, plus experience with interventions in infection prevention. So interventions to reduce CLABSI and CAUTI and VAP using this program known as the Comprehensive Unit-Based Safety Program, or CUSP. And CUSP is an approach that was originally developed at Hopkins, and then HRQ has kind of commandeered. They love CUSP. That is really designed to make healthcare safer and to have a strong focus on safety in healthcare by improving how all healthcare workers work together. So taking everyone on the team, valuing the wisdom of frontline staff to know where the problems are and to come up with solutions to the problems, and then a strong emphasis on teamwork and communication. So this was the model that HRQ wanted us to use. We had to do a lot of modifications because the group of people that are preventing CLABSI and CAUTI and VAP are different from the group of people that work in stewardship. So this is an overall framework of how we ultimately conceived of the program. We felt that we needed to work on 3 areas. One was making sure that places had stewardship programs, which is up at the top there. One was working on these safety culture issues, like how do you bring ownership of stewardship to the front line. And then finally, we recognized that there had, in the US, there's been a ton of work on stewardship process. What does a program look like? What should you do? What kind of intervention should you do? However, there hasn't really been good training in how do you steward certain infectious diseases. And so our notion was learning from what we had with syndromic stewardship, that we thought we could really provide some useful information for stewarding of very common infectious diseases. And all of this stuff was done under the framework called the 4 moments. I mentioned this briefly yesterday, but all of particularly the educational material about infectious disease syndromes is in the rubric of the 4 moments of antibiotic decision making. So this intervention was a year-long intervention with a 9-month actual intervention period and a 3-month lead-in period. We did 1 to 3 webinars per month on the topics that I mentioned. Over this year, we delivered each one 3 times because we had to deal with time zones in the United States. And each of these webinars also had a slide set and a script, so they could download them at any point, they could modify them, they could do whatever they wanted with them. The first set of webinars covered development of a stewardship program, and this is because we really do believe that people need to have a stewardship program. You just can't send people out to self-steward and not have the infrastructure of a stewardship program. Next, we moved on to webinars covering safety culture, teamwork and communication, behavior change. If you were at the session yesterday, some of that stuff I talked about was stuff we also used as part of the safety program. And this is because we know that we have to address behavioral drivers of prescribing and convince people to work together in improving prescribing. And then the bulk of the webinars over an 8-month period covered best practice in management of common infectious disease syndromes. So we did CAP, but we also did asymptomatic bacteria and UTI, skin and soft tissue infections, HAP-VAB, diverticulitis, biliary tract infections, C. diff, sepsis, and bacteremia. And as we have discussed, I think clinicians do like to learn by syndrome. We were able to organize this and repeat over and over and over the 4 moments of antibiotic decision-making. And actually, because each one was in a month, we also encourage the sites to say it's CAP month. So do everything you need to do to get everyone focused on CAP this month. And the same for all the syndromes. We also had some additional narrated presentations. These weren't delivered as webinars, but they were accessible on the project website about the role of nursing and stewardship, working with the micro lab and an approach to penicillin allergy, which were 3 areas we thought were important to cover. We developed 1-page guidance documents and user guides for developing syndrome-specific guidelines. So thinking that it's easier to be able to download a template and fill in what you want, we developed that for them. We made a bunch of posters. Here's one of the posters. This was the one they could hang up in patient care areas. But the idea was you could go to the website, you could print the stuff, you could hang it up. It was done for you. We also, and I think this was a critical component of this, had what we called implementation advisors. So each site had a human being that called them every month and said, how's it going? What's going on? How can we help you? What kind of problems are you having? Oh, let me take that back to the study team and help you solve these problems. And I think it motivated people to stay engaged, motivated people to submit their data and all of that. We also had office hours that Pranita and I did twice a month, so people could just call in and ask whatever they wanted. We mainly got a lot of infectious disease questions. These are the 4 moments of antibiotic decision-making. Does my patient have an infection that requires antibiotics is the first moment. The second moment occurs right after you decide you're going to give the antibiotics. Have I ordered appropriate cultures before starting antibiotics, and what empiric therapy should I initiate? The third moment is the daily timeout. We learned, as I said, we need to do this daily. So a day or more has passed. Can I stop antibiotics? Can I narrow therapy or change from IV to oral? And the fourth is specific about duration, because I do believe that duration is a very modifiable risk factor. So what duration do I need for what my patient has? So moment 1, we can't forget. There's an awful lot of antibiotic starts for no good reason. And we must remember that broad spectrum antibiotics are not a substitute for rational thought, which they are in our everyday lives. And it's unfortunate, but we've kind of over and over pointed out, you know, what's the differential of CAP? What's the differential of the red leg? Because we found that people don't even necessarily, they're not even able to provide this differential. They go straight to infection. So here are some examples on this slide. And then this also allowed us to educate about not every infectious disease must have immediate antibiotics. You know, just as an example, osteomyelitis. Like it's useful to get cultures because then you know what you need to treat. Moment 2 is getting appropriate cultures and starting appropriate empiric therapy. I think the culture part is fairly obvious, although in all the webinars we said, well, what kind of cultures should you get for this? And are cultures even indicated? and what are other diagnostic considerations. And then we talked about administering appropriate empiric therapy, really tried to get away from knee-jerk vancomycin and piptazo and really get them to think a little bit more of the subtleties of what they're actually trying to cover. And then also make decisions based on how sick the patient is. And we really did emphasize development of local guidelines and really emphasize that as a team activity. So not just the stewardship program making the guidelines, but during CAP month, you should invite the pulmonologist, you should invite the house staff, you should invite all the people in the emergency room to get together and make local guidelines. This is an example of the one-pager. This was the cholecystitis and cholangitis one-pager. But we really wanted to make it so they could print it out, fill in what they wanted for antibiotics, and it was done. And I think I've talked about these general themes that we wanted them to think about, but when are antibiotics not needed, how to make the diagnosis, illness stratification, avoidance of fluoroquinolones, and specific durations. And each of these documents actually has a longer document that tells them how to fill out the form. Moment 3 is the daily timeout. We made a daily timeout form. Really this was making them say every day, can I stop, can I narrow, can I change to oral? And really encourage them to make this happen on the units. And then finally, moment 4 is specifically about duration. This table is the back of the timeout tool. So they have all the recommendations on the back of the timeout tool. So it's easy to flip that over and get some recommendations. And I've talked a lot about duration already, but I really think this is an intervention that almost always works because we have good evidence. All of these durations have lots of references behind them, and the patient's better. So they're the whole risk-benefit issue for them is much easier when it's day 3 and they see the patients better and they can be more rational in their selection of duration. So what did we collect? We did not collect anything about resistance because that was just not humanly possible in this project that was across the country. So we collected days of antibiotic therapy per 1,000 patient days. We collected C. diff lab events, which are how these are reported to the CDC. And because we wanted them to get out of the office, we made them send us team antibiotic review forms. And these were forms that they would print out, take to the floor, and meet with prescribers in the hallway, in a meeting, however they wanted to operationalize it, and just pick patients any time in their course of antibiotics and run through a series of questions about what was going on with the patient. Did they really have an infectious disease? Were they on guideline-driven empiric therapy? Were they thinking about duration? And we made them submit these forms to us so that we knew that they were doing it. And so, because we felt like we couldn't just be passive with data submission. We needed to have some element of this that was doing something that they had to do and then submit. So we ended up with 402 hospitals completing the program. This is the US, and so we had good representation across the different states in the United States, except for Montana, where we had no one, and notably Iowa, they're very engaged. They're the first places with the primaries and so forth, so they probably were really into the stewardship also. So these are the types of hospitals that participated. Critical access hospitals in the US are these little tiny hospitals. Sometimes they have 10 beds. They're very small. But they really expressed to us, please let us enroll because we don't have other resources. So 21% were critical access, 30% were mid-level teaching hospitals, which are basically community hospitals with a training program with house staff. 42% were community hospitals with no training programs, and the fewest number were academic medical centers, which is not surprising because that's not where the stewardship need is. Most academic medical centers already have stewardship programs. And these were the units that participated, so mainly med-surg floors, but 35% were ICUs also. So we had an average of 561 attendees per webinar. And that a lot of people did the webinars together in a room, so that there were probably more per webinar than that. An average of 470 downloads per item from the safety program website, and almost 4,000 initial email inquiries to the help desk. That was a lot of fun. Data submission, we had, I think, pretty good compliance with data submission. 88% compliance with submitting monthly data of antibiotic therapy. And if they submitted it, they got a feedback report that compared them to their peers, so like hospitals. So there was a feedback loop in this program. 89% compliance with C. diff data, and I think cool, 85% compliance with submitting the team antibiotic review forms. So these are the results. We did see a decrease in overall antibiotic use across all hospitals. We did some subgroup analyses, some of which were significant and some of which weren't, but overall, and I will say that we stole this from the Marino study, there was a decrease in antibiotic use regardless of how we slice the data. The actual overall reduction, I will say, in antibiotic days is not insanely impressive, but this was really just 9 months into stewardship in a lot of places that hadn't been doing any stewardship. So we do feel that this made a difference. We also saw a reduction in C. diff rates that was statistically significant. And I think this makes sense because we reduced overall use, and we particularly, that reduction was actually driven by fluoroquinolone reduction. So that's probably why we did see this reduction. So I'd like to say we saw this massive change. We didn't. We saw a modest change, but I still think, knowing what I know about stewardship, that that was real and that this did have an impact for a bunch of places across the country that really had not been that well touched by stewardship. This is certainly a study with limitations because we didn't have funding for sites. They had to do all of this on their own. They had to, many of them, hand collect antibiotic use data. Many of them, for the first time, reach out to IT and say, how can we get these data? We did not standardized prescribing. So they still had to say, what are we going to do in our hospital? But we gave them a lot of guidance about things they could think about. And we relied on the sites to submit accurate data. We did review all of the data for internal consistency, made a lot of queries back to the sites. So I think it's pretty decent data, actually. We did see a large variation across the country in stewardship knowledge and stewardship infrastructure, and clearly the access to ID expertise was a huge thing for them. They would call us and ask every single ID question that they could think about, and many of them had no physician, let alone ID physician, to do that in their own hospital. Most of the participants on the webinars were pharmacists. Very few of the pharmacists had any training in infectious diseases. And we've actually heard back from a lot of the pharmacists who have told us specifically that the benefit that they felt was that they could now be on the same page in discussions with physicians about infectious disease issues. And so that made us feel good. So the next steps for this project, the acute care materials are going to be publicly available in like a day. It was supposed to happen yesterday in the US, which was, I don't know what that was here, something around the same time. But I expect these will be up next week, and they are for everyone to use. And we would actually love it if people use these materials because we spend a lot of time on them. The long-term care intervention is ending in December. Preliminarily, it looks like we're going to see reductions in antibiotic use in long-term care also. And then ambulatory, as I said, is starting in December. Just so you know, if you ever think of following up, we're going to have toolkits for long-term care and ambulatory care eventually also. And there are 4 moments for both long-term care and ambulatory care, but they are modified based on those individual settings. Just for example, the 4th moment of ambulatory care is, does my patient understand what to expect in the follow-up plan? Here's the website for the toolkit, but you can actually just Google AHRQ safety program, and I think it will come up. So just to finish up, and I know that was long, reducing resistance is clearly the end game of stewardship, but it may not be easily measurable, and it does not necessarily drive real-time clinician behavior. So I think we have to be satisfied in our heart that we are making a difference and not obsess over proving that what we do is reducing resistance. I do think that improving and reducing antibiotic use are reasonable surrogates and definitely important patient safety goals, if not also, healthcare goals overall to streamline our healthcare system. And we really believe in framing the goal of stewardship as improving patient safety outcomes with our frontline clinicians. That really seems to resonate more than reducing resistance. Interventions are more likely to be successful when frontline clinicians are actively engaged. I hope I've made that point over the past 2 days. I think we really have to have ongoing attention to interventions. It's easy to say, and you may have this also, that now we have a standard, now we have a this, now we have a that, we've solved the problem in acute care, let's move on to other things. We haven't solved the problem in acute care. We have a lot of work to do in acute care. We have a lot of work to do across the continuum, but we can't just say we've done everything. We have to keep moving forward. And so this is the team. We've had an adult stewardship program since 2002, a pediatric program since 2012. Pranita's in the purple shirt, my partner in crime. We have 2 pharmacists that I work very closely with, Adina Avdic and Kate Zintars, and then Sarah Keller with the red hair is leading the ambulatory safety program, and Morgan Kath is leading the long-term care safety program. So we have an awesome group, and then Valeria in the middle is doing all the work with nursing and stewardship. So, and Alice is the pediatric ID pharmacist. So this is the group of people that has done everything that I have presented to you today. So they're awesome. That's it, thank you.